Hello, my name is Saul Wiener, and this is the fifth in a series of videos on the topic of contextualization of care. In the first two, we addressed questions such as what is patient life context and what's a contextual error? And I also introduced a four-step process to contextualization of care. In the third and fourth videos, we looked at some of the research evidence that underpins this body of work. In this presentation, we'll be having a look at the coding system, the audio coding system called Content Coding for Contextualization of Care, or 4C for short, which I've mentioned on a few prior occasions. 4C is so important because it provides an objective measure of contextualization of care. This presentation is divided into two parts. First, I'll be introducing some essential concepts and providing a few examples to illustrate how and why 4C is so helpful. And then I'll be turning it over to Amy Binns-Calvey, who has been instrumental in the development of the 4C coding system and has enormous experience using it. So let's get started. Before we get into the details of 4C coding, I'd like to review some of the multiple uses. First and foremost, 4C is an objective method of assessing whether a care plan is contextualized. It also shows where an error occurred when there is either a failure to contextualize care or a near miss. It's also a performance measure and an educational tool for clinicians, and we saw this in some of the previous videos. And finally, of course, it's an essential tool for researchers studying contextualization of care. So 4C is done by trained coders, and it takes several days to learn, followed by a period of supervision. It requires access to a patient's medical record and an audio recording of the visit. Coders extract contextual red flags from both the medical record and the audio recording. Then they listen for contextual probes, contextual factors, and contextualized care plans on the audio. And then optionally, 4C coders can return to the medical record 4 to 6 months after the index visit, the visit that was recorded, to determine what the outcomes were for the contextual red flags. A fundamental coding principle is the preconceived ideal. 4C coders reduce subjectivity by deciding what would constitute an ideal contextual probe based on the contextual red flag before listening to the clinician's response. They also decide what would constitute an ideal plan of care based on the contextual factor also before listening to the clinician's response. You can think of this as a kind of anchoring. They also apply several rules for making decisions in ambiguous situations. And by utilizing this preconceived ideal principle and combining it with these rules for determining tough calls, coders are able to achieve 85% inter-rater agreement. And the coding process takes about 1.5 times the length of an audio recorded encounter. Now, as I mentioned above, 4C does serve a kind of diagnostic role when you're trying to figure out what went wrong. It can distinguish among clinical encounters in which a clinician missed a clue, a contextual red flag, that a patient might be struggling with a life issue, a contextual factor that is complicating their care, or missed a contextual factor by failing to address it in the care plan, that would be a contextual error, or missed a contextual red flag, but then addressed the contextual factor after it was revealed by the patient unsolicited. We call that a contextual near miss. So for instance, a patient with a history of a stroke has missed a lot of appointments in the prior year, mostly to physical therapy. So now let's apply the preconceived ideal method here. The ideal probe would be, I notice you've missed a lot of appointments to physical therapy. Can you tell me what's happened? That's based on the premise that we start with an observation followed by an open-ended question. The probe heard is, quote, why have you been missing so many appointments, as we just saw? So is this close enough to count? The coder would say yes, because from a content standpoint, the two match. They're both getting at the same thing, just putting it a little differently. Contrast that with, again, the ideal probe. I notice you've missed a lot of appointments to physical therapy. Can you tell me what's happened? And this time, the coder hears, it's important you do all your physical therapy to have the best outcome. Is that close enough to count? No. And of course, that's because the probe heard is substantively different from the ideal probe. It's really not going to elicit the information that's necessary based on the red flag. And as I mentioned, this preconceived ideal method is also applied to the plan of care, although I'm not going to show that here. So if we go back to this example and see how it plays out in an ideal situation, the red flag again is patient with a history of a stroke has missed a lot of appointments in the prior year, mostly to physical therapy. The actual probe here, which as I said is close enough to the ideal probe to count, is why have you been missing so many appointments? The reply from the patient is, they scheduled my physical therapy appointments at a new location and there isn't a bus that goes there. Only sometimes can I get a ride. So that's the contextual factor. That's what's going on. And the clinician says, looking online, I see that the place you used to go to now has openings again. How about I just reschedule you there? And the patient agrees. So that would constitute a contextualized plan of care because it's a reasonable attempt to address the contextual factor. So now let's look how this might play out if there were a contextual error. Again, patient with a history of stroke has missed a lot of appointments in the prior year, mostly to physical therapy. This time, again, the probe is good. Why have you been missing so many appointments? Again, the contextual factor is aptly revealed. Quote, they scheduled my physical therapy appointments at a new location and there isn't a bus that goes there. Only sometimes can I get a ride. But this time, the clinician just replies, that's frustrating. So as you can see, that would not count as a reasonable attempt to address the contextual factor. And finally, let's look at what we call a contextual near miss. Again, the red flag is patient with a history of a stroke has missed a lot of appointments in the prior year, mostly to physical therapy. This time there is no probe, meaning the physician kind of drops the ball, didn't pick up on the red flag and didn't probe it. But the patient just goes on without being asked to share what they're struggling with. They say again, they scheduled my physical therapy appointments at a new location and there isn't a bus that goes there. Only sometimes can I get a ride. And after being hit over the head with the issue, the physician this time responds and says, looking online, I see that the place you used to go to now has openings again. How about I just reschedule you to go there? And the patient agrees. And as I mentioned above, we can also track the outcomes, typically at 4 to 6 months. So in this example, let's suppose the contextual red flag, to be a little more specific, is that the patient has missed 8 out of 20 physical therapy sessions. So that's 40%. The outcome of interest would be, did the contextual red flags, in this case missed appointments, fully or partially resolve after there was a reasonable attempt to contextualize care or a contextual error? So a positive outcome here would be that the patient misses fewer than 40% of their physical therapy sessions over the next several months. The actual outcome is that they missed only 1 out of 4 appointments, so that's 25%. So would that count as a positive outcome? Yes. So the process for collecting these audio recordings is that patients volunteer to carry encrypted audio recorders into their visits. The audio recordings are uploaded to a secure server and a trained audio coder listens to the recording while also accessing the patient's medical record. In a prior video, I go into more detail about how this process is carried out, and I've included here a couple of references to papers we've written about how this is done. In the segment you're about to see with Amy, you'll see that she's putting the data into a web application for building and managing online surveys that's called REDCap. It's not the only system that we use. We've done this in Excel, but this is the one that we found to be most user-friendly. As we go into this next segment, imagine a coder who has their headphones on, they're listening to the audio of a visit, and they have the patient's chart open. They're going to be extracting contextual red flags from the chart first and then listening to the audio. They're going to be using a drop-down menu in REDCap to assign contextual red flags to categories and to contextual factor domains. For example, barriers to access to care, loss of social support, and so on. And this will enable the analysis. And after watching the rest of this video, for those of you who are interested in a deeper dive, we have a coding manual online, provided a link to it as well below this video. There's also a Contextualizing Care website, and here's contact information for me if you'd like to reach out directly. And so, here's Amy.
Hello, I'm Amy Binns-Calvey, a co-creator of content coding for Contextualization of Care, or 4C for short. I also developed this REDCap project to capture the 4C coding. If you have downloaded the manual, many of the examples are given in an Excel format. This tutorial should provide you some guidance if you want to capture your coding in REDCap. In this video, I'm going to be reviewing entering 4C coding into REDCap, but I won't be going over how to set up a project. There are many great online tutorials that go over all the great things that REDCap can do. I'm also not going to be doing a deep dive into 4C itself. Again, you can refer to the 4C manual for all the nuances of 4C coding. If you watch Dr. Saul Wiener's intro, you know that 4C coding is based on chart review and audio recordings. We won't be looking at actual charts or listening to any recordings, but I will talk you through a couple of examples so you can see how to capture the items in REDCap. So if you look on the screen, you can see that I have my project open, and I am going to click Add a New Record. You will see that there are 3 instruments here in REDCap. We are going to be starting with our first instrument, the 4C Encounter Info. And this is the demographics and the info for the actual appointment. So this is being coded by me, Amy Binns-Calvey. The date of the encounter will make it today. The patient ID, we de-identify our data for the patients, so we're going to give our patient the number at 111. Did the patient see the wrong provider? For our example, we're going to say, nope, they saw the correct provider. And then I'm prompted to give also an ID for that provider. We'll just make it 111 for today. Was the recorder revealed? This is an item that I will have to come back to after I have listened to the entire recording. And the reason why we're tracking this is sometimes our patients will show the provider the recorder in their pocket or their purse. And we just want to keep track of that in case that influences the provider's behavior during the visit. The next item is, did the recorder fail? We're going to say, nope, we have a recording. And so now I'm going to save and exit the form. As Dr. Wiener mentioned, the 4C includes looking at in the chart for red flags as well as the audio. So I'm going to go to our next instrument, 4C coding, and I will start off by looking at the patient's chart. So it's a chart coding that I'm doing. As I look at the chart, I'm looking for any indications that there might be something going on in the patient's life impacting their ability to manage their care. And in this case, I did identify a red flag. Looking in the patient's chart, again, the red flag type is a chart, I see that patient missed 10 out of 20 visits for an SAA of 50%. An SAA, once you look at the manual for 4C coding, is what we call scheduled appointment adherence. And in order for us to calculate an SAA, a patient needs to have had at least 16 visits in the past 12 months. When I go down to the next item, you'll see that, as Dr. Wiener had mentioned in the introduction, we have close to 70 red flags that we have categorized from our years of coding, and they fall into these 9 different categories. We have a level of red flag, like an SAA, that is a high impact red flag, and these are the red flags that are easily quantifiable in order to follow up later on to look for outcomes. But here you will see I have a drop down of these 70 red flags that we have already identified, and we have a catch-all at the end, which would be an other, in case there is something that doesn't neatly fit into one of our categories, but you still think that it's an indication that the patient has something going on in their life. But as I said, I know that this particular red flag, since the patient had an SAA of 50%, that is definitely less than 75%. So we are going to choose that for our red flag. Now that I know what the patient's chart red flag is, I'm going to go ahead and formulate an ideal probe. And in this case, our ideal probe is, I noticed you missed many appointments. What is going on? The reason why we have an ideal probe, as was mentioned in the introduction, is that this is an anchor for me. So when I go to listen to the audio, I will be able to see if there's something that the provider says that is close to my ideal probe. So at this point, I have identified my ideal probe, and I am going to save and exit the form. Now I'm going to be listening to the audio, keeping in mind that I'm listening to see if the provider asks about missed appointments or if the patient reveals a contextual reason for missing those appointments unprompted, or if the patient reveals another red flag. As I'm listening, I hear the patient say, I haven't been taking my pills in weeks. What I would do then is I would pause the audio and I would go down here to add a new red flag. And in this case, it is an audio red flag. Yes, there is a red flag. Yes, it is an audio red flag. And what has happened is that our patient has made the statement, I'm not taking those pills in weeks. And I'm going to go ahead and just copy and paste because I have already typed these in, but I would normally type this in. I haven't taken those pills in weeks. We're going to go to our drop down again. And luckily, the more you code, the easier it gets to identify and remember what these red flags are for their numbers. So in this case, we are looking for missed medications. And here we're going to see the patient is unable or declines to take medications as prescribed. That's going to be the red flag that I pick. Now that I know what the red flag is, now I'm going to identify what I think is an ideal probe. And in this case, my ideal probe would be, why aren't you taking those pills? So I would restart the audio and continue to listen to see if our provider says anything about the pills. As I'm listening, I'm going to save and exit form. And the reason why I'm doing that is because now it's a nice way for me to see what are the two things that I am listening for. So I continue to listen, and our provider does not say anything about the medications that are being missed, but I do hear the provider say something about missing appointments. I would pause the audio, I would open back up this red flag, and I would go down here, and I heard the provider say, why have you been missing so many appointments? So was a probe heard? Yes, it was. What was the probe? Provider said, why have you been missing so many appointments? Was this a contextual probe? Yes. And we're looking to see, are they asking about a patient's context, something about their life circumstances? Is this a close enough probe? Is it close enough to my ideal to count? I'm going to say, yep, it's pretty darn close. And then I'm going to go back and continue to listen to see if the patient reveals a contextual factor. In our case, our patient does reveal a factor. Yes. It was in response to the probe because the provider said, why have you been missing so many appointments? And what I had heard was that the patient said, and I'm going to copy and paste so you don't have to watch me type. The patient said, they scheduled my physical therapy appointments at a new location, and there isn't a bus that goes there. Only sometimes can I get a ride. Now that we know the factor, I'm going to pick the domain that that factor falls into. And again, during the introduction, you saw that Dr. Weiner explained how we had the different domains. In this case, because the patient cannot get to his appointment, we are going to say that is access to care. The next item on my list here, is it possible that this factor is actually patient preference? Sometimes you will hear a factor revealed, and quite often this is something that will primarily be maybe getting a vaccination, and the patient actually just doesn't want to, even though they might say a different reason. And you as a coder might be able to tell that it could possibly be preference. But in this case, we can tell that our patient would like to come to their PT appointments. And so this factor is not patient preference. And now that we have the factor identified, I am going to go ahead and put in here, similarly how I put in the ideal probe, I'm going to put in the ideal outcome for this red flag. And the ideal outcomes are always a resolution of what the red flag was. So if I scroll back up, I can see that the patient had an SAA of 50%. And so our ideal outcome is going to be an SAA greater than 50%. I am also going to put in an ideal plan of care to address this factor. So since this patient is having trouble getting to their location, my ideal plan of care would involve something along the lines of change the location of the PT appointments to one that the patient can get to, or refer the patient to a social worker to identify some workable plan for transportation, such as a van service. I will start the audio back up and listen to see what our provider does. In our example, our provider does a great job and does make a plan of care. And the plan of care that I hear our provider says is, looking online, I can see that the place you used to go to now has openings again. How about we just reschedule you there? Was this a contextual plan of care? Yes, it was. Was it close enough to my ideal to count? Yep, it sure was. Was the plan of care carried out during the visit? No order necessary. Sometimes a plan of care, if it is something like an education, will take place during the visit, and there won't be an order placed in the medical record. This will come into play when we go back and look for outcomes, if that's what you're going to be doing. This will make more sense when we go to the next instrument. But in this case, because our provider said that they were going to put in an order for them to go back to the original physical therapy location, we're going to say that the plan of care was not carried out during the visit. This is an open text box for coder comments. So if I wanted to type something in that I think would be of interest in the future, it could be provider picked up on the red flag right away, or anything that I think would be of interest later on when we're reviewing the codings. Same thing here. There's one more option here. We put together reports based on our coding and we present them to the providers. And sometimes it's very helpful to have a good narrative example to use in a report. This is a pretty great example. So I'm going to click yes. We have now completed everything for this one encounter before somebody goes back to look for outcomes. So I am going to go ahead and say that this one is complete. Now we still have another red flag, so I'm going to save and exit the form so we can go back and remind ourselves we're still listening to see if the issue of medications comes back up. So I will start the recording back up again to see if that red flag is probed or if anything else comes up during the visit. As I'm listening, I do not hear our provider ask about the taking the medications as prescribed. But as our provider is continuing with the encounter, the patient spontaneously reveals a reason for not taking the medications. I would pause the audio, go back here to this red flag, and in this case, I did not hear a probe, but a contextual factor was identified, and it was spontaneously revealed by the patient without a probe. And what I heard was the patient say, yeah, they changed my medication coverage and I just can't afford all of my meds. Again, I would pause because I want to pick what domain is this in. So the patient said, I can't afford my meds. That would be a financial situation. Again, is it possible that this factor is a patient preference? I'm going to say no. Because there is a factor identified, what's the ideal outcome for this red flag? And again, the ideal outcome would be a resolution of our red flag. So since the patient hasn't been able to take their pills, the ideal outcome would be patient is able to take meds as prescribed. What would the ideal plan of care be to address this factor? So we saw that the factor is a financial situation, and that is why the patient can't afford the pills. And so our ideal plan of care would be to check insurance formulary for covered alternative and or a cheaper generic. I would start the audio back up and listen to see what our provider says. In this case, again, we're in good luck. Our provider does make a plan of care. And the plan of care that I hear is that our provider says, let me check and see what your insurance plan will cover. My staff will check and get back to you. In the meantime, we have some samples to tide you over for a few days. Was the plan of care contextual? Yes, it was. Was it close enough to my ideal to count? Yes, it was. Was the plan of care carried out during the visit? No order necessary. Well, our provider said that they might be changing the prescription to see according to what the insurance plan covers. So I'm going to say no, that would require an order to be placed. But I am going to put a little note here to myself to say samples were given during visit, just in case there isn't a cheaper alternative, but we know that this provider did have a contextual plan of care to at least address the issue in the short term. Would you like to designate this to be used as an example for a future report? I'm going to go ahead and say no. And now this is complete. I will save and exit the form. I would go back and continue to listen to the audio in case another audio red flag is revealed. For the sake of our example, I'm going to say that no second audio red flag was revealed. Now what would happen is 4 to 6 months later, a separate coder would come back and look for outcomes. Not everybody needs to look out for outcomes, but if you decide to follow up, it's great data to have. So 4 to 6 months later, a different coder would come and check for outcomes. So they're going to click here on outcomes. And you will see, first you type in the returned visit or date the record was checked for outcomes. We're going to say that this was 4 months after the initial visit. The ideal outcome, and this is pre-populated from what we had in the other form, is that the SAA is greater than 50%. And we're going to say that I, as the outcomes coder, have gone in and looked, and I saw that the SAA now equals 75%. And I'm going to say that is a good outcome. Now that I have identified what the outcome was, I am going to go back and I'm going to look to see if there were orders that needed to be placed and were they placed. And the reason to do that is sometimes the audio coder will hear the provider say that they're going to put in an order and then it doesn't actually get put in. So we want to make sure that we're tracking that, because in case the ideal outcome was poor, we would want to know whether or not that actual plan of care, those orders were actually placed. So as the outcome coder, I'm going to save and exit the form. And then I can see that these outcomes were for red flag 1. I'm going to go back into that coding and I am going to scroll down and I'm looking for 2 things. I am looking to see, was the plan of care carried out during the visit? No order necessary? And I can see no. So there should have been an order necessary. So then I'm going to look at the plan of care. And I can see here that the provider was going to reschedule visits at the physical therapist. So I would look in the medical record and see if that order was placed. I'm going to go back. And for the purposes of our example, we are going to say that the orders for the plan of care were placed. And now I can say that this is complete. And I am going to save and add new instance because I know that there's another red flag. And here we can see there is a second outcome to look for. I am still looking for on the same date, so it's 9/21/21. And this one is the ideal outcome is patient is able to take medications as prescribed. And we'll say again, I look in the medical record and I see in the notes that somebody has written, patient is taking all meds as prescribed. This is again a good outcome for this patient. And we're going to do the same thing we did before. First, I'm going to save and exit the form. I'm going to go to my red flag. I'm going to scroll down and I'm going to see, was the plan of care carried out during the visit? No order necessary? Nope, I need to look for an order. So then I'm going to look up here and see what the order would be. And so it looks like I'm looking for an order to see if new medications were placed that are an order for cheaper medications. So I'm going to save and exit, go back to my outcomes. And in this case, yes, I looked and I saw that the provider was able to order a generic version of those medications. And I am now able to say complete and save and exit the form. Now, if you remember, the great thing about REDCap is that it will give us these color codings when we can say something is complete. In this case, if you remember when we started off, I was unable to complete this because I had to indicate whether or not the recorder was revealed. And for the purposes of our example, the audio coder said, nope, the recorder was not revealed. They kept it hidden throughout. And now I can say that this is complete and save and exit the form. So this was a speedy version through how to add the 4C data into REDCap. I hope that it was helpful. And as I mentioned, you can get a lot more information if you go online and look at the 4C manual.